Right. Thank you so much for the introduction. As Natalie mentioned, my name is Carolina Arana, and I really worked on developing a community engagement framework to support local climate adaptation efforts. So before I begin, I want to make space to express gratitude and acknowledge that my practicum was completed on the traditional, ancestral, and unceded territory of the Syilx people in the Okanagan region of BC. However, I completed my practicum with Interior Health, one of the 5 regional health authorities in BC, which also resides and occupies the lands of 54 First Nations communities and 15 Métis chartered communities. However, my work focused more specifically on the Kootenay Boundary Health Service Delivery Area, which I will be referring to KBHSDA for short, which is home to the Sinixt, the Ktunaxa, the Syilx, and the Secwepemc people. So I had the privilege of completing my practicum with the Population and Public Health team at Interior Health. Throughout my practicum, I worked on a variety of projects related to climate change. However, my practicum really centered on creating an engagement framework to support the implementation of IH's first climate change and health vulnerability and adaptation assessment, or CCHVAA for short. And then once completed, the framework was actioned to create an engagement plan for the KBHSDA, one of the 4 HSDAs covered by Interior Health. And the KBHSDA is just highlighted and red over here. So what exactly is the issue? So in BC, extreme climatic events due to climate change are projected to become more severe and more frequent. In the Interior Health region, this warming trend is expected to exacerbate several climate hazards, such as, but not limited to, extreme heat, cold, flooding, and wildfires. So as many of you know, this was exemplified by the heat dome event in 2021, which led to the deaths of 64 individuals in the region. Individuals with chronic health conditions, the socially isolated, the insecurely unhoused, low income, people with disabilities, and outdoor workers were found to be the most severely impacted. So in other words, these groups were found to experience a higher level of vulnerabilities in response to this climate event. So what exactly is vulnerability in the context of climate change? So vulnerability is framed as a function of a community's exposure to climate hazards, their physiological sensitivities to those impacts, and the ability to adapt and reduce the severity of health impacts in response to these changing circumstances, otherwise known as their adaptive capacity. So although this formula provides a fairly general framework to conceptualize vulnerability, it's important to acknowledge that it doesn't really provide the full picture. So over here, this is just a graphical depiction of how vulnerability is shaped by the determinants of health. So at the individual level, vulnerability is influenced by determinants of health such as socioeconomic status, housing, quality, education, and many more. Structural systems of oppression, such as racism and oppression, also influence an individual's vulnerability to climate-related health risks. Determinants of health interact and intersect with inequities in complex ways that render the experience of diverse groups and individuals very unique. So though it is important to acknowledge that everyone is affected by climate change, not all individuals are equally at risk. So based on this understanding, a CCHVAA is an evidence-based tool that is designed to better understand this vulnerability in local communities. So these assessments often shine a light on health equities considerations, since regional health authorities are encouraged to identify specific populations that are more or less vulnerable to local climate hazards. As a part of this process, key interest holder engagement and consultation is essential, more specifically when it comes to understanding the adaptive capacity of local communities. So in order to engage with communities and Indigenous key interest holders in a meaningful way and to provide a more local depiction of adaptation to climate change, Interior Health decided to scope the assessment sub-regionally. So this first assessment was really meant to capture the vulnerability of communities in one health service delivery area at a time. The first application of this tool is really meant to inform the short and long-term planning related to climate resilience and adaptation in the regional health authority and in local communities as well. So I want to dive right into the project roadmap. So based on the regional scope of the assessment tool, the first stage really involved identifying the pilot region for the CCHVAA. Next, I began to work on developing the engagement framework, which was really meant to facilitate the engagement with the 4 HSDAs. And the final stage involved implementing the framework and developing a tailored engagement plan for the pilot region. So before I get to the implementation of the framework, I wanted to give you a very high-level overview of my methods. So to identify the pilot region, this really involved reviewing the population dynamics of each HSDA, and the decision truly considered the region's potential to benefit based on vulnerabilities, the capacity of interior health to leverage their existing relationships in the region, and the community's readiness to engage. So based on this criteria, we chose the KBHSDA. For the engagement framework, this involved a review of peer-reviewed and gray literature. So I really tried to focus on finding frameworks that could be applied to climate adaptation work at the community level, frameworks that applied a health equity lens, and frameworks that applied best practices in community engagement. And based on the literature review, this was identified as principles outlined by the International Association of Public Participation, or IAP2. And finally, to implement the framework and come up with a tailored plan, I reviewed gray literature, and this was really just the major output of this was identifying the key interest holders in the region and really understanding that community context. So the engagement framework. So I created this figure to illustrate how the 4 major sections of the framework come together. Design, plan, apply, and learn are steps that mirror the major sections of the IAP2 practice framework that is considered a best practice in community engagement. The sections are divided into subsections that include action items and/or key guiding questions, methods, and tools. So the process that I'm proposing is highly iterative and will likely be adjusted during engagement as the engagement team evaluates and adapts the approach to really reflect the unique context of the region. So I just wanted to provide a visual of that breakdown that I just spoke on. So the first section is design here, which is broken down into further sections, including action and/or guiding questions, and the methods and tools I included in the appendices. In total, I created 7 tools to support the engagement, and some of these included a Gantt chart for the engagement activities, proposed guiding questions, and a risk and analysis opportunities table as well. So for the engagement plan in the KBHSDA, this really required the implementation of the design and plan sections of my framework. So in the interest of time, I tried to condense the plan and really focus on the major outputs. The overarching goal of the engagement plan was really to develop an understanding of the current adaptive capacity of communities in the KBHSDA, to provide community decision makers with data to inform and prioritize short and long-term climate adaptation strategies as a part of that wider CCHVA process. Based on the IAP2 spectrum, the determined levels of engagement were share information or inform, consult, and involve. And with the highest level being the involve level, this really, the higher goal here is really two-way communication. The key interest holders that were chosen for the engagement were representatives from local governments, and this include regional districts and municipalities, as well as Indigenous organizations, community organizations, including ones representing people that experience vulnerabilities in the region, youth groups, and academic partners. Virtual workshops and virtual key informant interviews were chosen. And the reason I wanted to design it as a virtual engagement was really based on the capacity of interior health. However, in-person sessions were still recommended. And one of these recommendations was really to meet people where they are. So this is a principle that encourages engagement teams to engage with groups who already have established relationships, who hold regular meetings and events. And finally, for the refine stage, I outlined in my framework that pre-engagement sessions with key interest holders is imperative in order to receive feedback on the engagement approach. And I really see this step as an embodiment of the principle, nothing about me without me. So for example, IH held pre-engagement session with a variety of key interest holders, and this included representatives from the Circle of Indigenous Nations Society, a nonprofit society that serves Indigenous folks in the West Kootenay boundary region. And based on this meeting, we decided to modify our engagement approach from one-on-one interviews to a more group-based type of approach. And finally, What is the significance and really the future implications of developing this plan and engaging with communities? And I really see this as an opportunity to gather information about locally led climate adaptation actions, to create partnerships in the community, to apply health equity lens to the CCHBAA process, and to support local Indigenous-led climate adaptation actions, to employ a bottom-up approach to advance climate-focused priorities, and really create and support initiatives that promote the co-benefits of health. And finally, ultimately, the goal is to strengthen community resilience to climate change. And before I go, I just want to say thank you to my supervisors, Sir Dr. Sue Pollack and Julian Mounds, and as well as Katie Hunter, and truly the rest of the population and public health team. They are absolutely wonderful. And I also want to express my gratitude to Dr. Jaime Redondo, because he was incredibly supportive throughout my practicum. So yeah, that's all I have for you. I'm excited for your questions. Thank you.